Good evening. I'll be talking on proportion of vision-threatening diabetic retinopathy on initial diabetic retinopathy screening in a tertiary eye care hospital, Kerala. Diabetic retinopathy at the earliest stages is largely asymptomatic. Patients need to undergo regular screening to detect treatable retinopathy before vision is affected. Vision-threatening diabetic retinopathy includes advanced stages of diabetic retinopathy. In recent population-based multi-center study in India, the national prevalence of DR and VTDR were 12.5% and 4% respectively. In this study, we propose to identify the proportion of diabetic patients who present with VTDR on their initial diabetic retinopathy screening. VTDR includes severe non-proliferative diabetic retinopathy, proliferative diabetic retinopathy, and diabetic macular edema. Aim of the study is to determine the proportion of vision-threatening diabetic retinopathy among diabetic patients on initial DR screening. This was a hospital-based retrospective observational study. Data of 533 people with type 2 diabetes mellitus getting screened for the first time for DR at Retina Clinic of a tertiary eye care hospital, Kerala. Data was collected over 7 months in 2024 from January to July. All diabetic patients more than 18 years attending regular outpatient department undergoing their first DR screening were included in the study. Patients with significant media opacities, other retinal pathologies such as age-related macular degeneration, muscular occlusion, vitreomacular interface diseases excluded from the study. Also, diabetic patients on regular follow-up and prior treatment for DR were excluded. Data collection included basic demographics and ocular parameters. Fundus examination was done using slit lamp biomicroscopy with 78D lens and direct ophthalmoscopy with 20D lens. Grading of DR was performed using International Clinical Diabetic Retinopathy Severity Scale, and fundus photo and OCT were performed in necessary patients. Chi-square test and independent t-tests were the statistical tests used to compare the gender and age differences within the VTDR group, and p-value of less than 0.05 was considered statistically significant. Coming to the results, 76 out of 533 diabetic patients were presented with VTDR. 14.3% were found to be VTDR. Mean age of presentation was 61.7 plus or minus 9.3 years. 56% were females and 44% were males. Almost 60% of patients were found with no diabetic retinopathy and 40% presented with the diabetic retinopathy. 4.7% present with severe NPDR, 6.6% present with PDR, and 3% present with center involving DME. PDR patients were the highest percentage of group among VTDR patients. VTDR trends in gender category, males had a higher proportion of VTDR compared to females. Age group in VTDR patients are significantly younger on an average than those without VTDR. Coming to discussion, VTDR seen at presentation were 14.3% of type 2 diabetes patients undergoing their first DR screening, higher prevalence among younger individuals and males. 60% of patients did not have any DR and 28% presented with early DR. Proportion of VTDR higher than the national prevalence-based estimates, which reported a 4% prevalence of VTDR among people with diabetes more than age 40 years. This high proportion in our series is consistent with trends observed in other hospital-based studies, which typically report greater VTDR prevalence due to opportunistic screening, referral bias, and inclusion of symptomatic patients. Speed study conducted across multiple tertiary eye care centers reported a DR and VTDR prevalence of 32.3% and 19.1% respectively. Our findings of VTDR were higher than that reported from previous hospital-based studies in Alaska, that is 4.2%. An Ethiopian hospital-based study found 13.7% VTDR with male gender, poor glycemic control and hypertension, and longer duration of diabetes as identified as significant risk factors. Another study by Glover et al. Found that 19.7% cases of VTDR in patients attending a hospital in sub-Saharan Africa. Another study by Subkota et al. Found 80% of patients attending a specialist eye clinic in China had VTDR with 67% prevalence among first-time attendees, male gender, longer diabetes duration being significantly associated. The relatively higher proportion of VTDR in our first-time screening cohort highlights the delay in presentation of DR screening. Delayed screening and lack of awareness positive symptoms in the early stages of DR contribute to burden of advanced disease at diagnosis. Early DR is asymptomatic, and vision loss due to VTDR can be largely prevented through systematic screening, timely laser and anti-VEGF treatment, and optimal control of modifiable risk factors such as hyperglycemia, hypertension, and nephropathy. Our recommendations from the studies integrate DR screening into routine diabetic care pathway, strengthen referral system, enhance patient education to prevent irreversible visual impairment during the most productive years, mandatory DR screening for younger onset DM patients. Strengths and limitations of the study. Strengths: exclusive inclusion of first-time screening attendees providing an accurate snapshot of disease burden at initial presentation, relatively large sample size, use of ICDR classification ensure the methodological robustness and allow comparability with other studies. Coming to limitations, risk factors such as longer duration of diabetes, poor glycemic control, presence of comorbidities were not included in the study. Retrospective design precluded the collection of complete data and reasons for delayed presentation, and regional settings in Kerala findings may not be generalizable to areas with different healthcare access and demographic profiles. We concluded that VTDR was found in 14.3% of type 2 diabetes patients undergoing the first DR screening with higher prevalence of younger patients and males. These findings underscore the urgent need for early and routine DR screening to prevent irreversible visual impairment. These are the references.
Two important things are the duration of diabetes and the HbA1c. Both were not analyzed. We don't know what was the duration. Number two, I think yours is a tertiary eye care hospital. It's not a general hospital. So all these patients were screened in the retina clinic, or you have got a general ophthalmology also where it was screened. Because the patients coming to retina clinic will be having some issues, either referred or with morbidity. So naturally, the incidence of the prevalence of vision-threatening diabetic retinopathy will be more. So have you screened the patients who are coming to general ophthalmology also with the diabetes without any
Yes.
referral?
Yes, sir. All general cases were included.
Was it entirely the patients who walked into your hospital, or did you do a community screening along with that to identify
Not
this?
included the community screening, like a patient with first DR screening came to the hospital was included. All diabetic patients were included.
Okay, then one more question. You repeatedly said prevalence of vision-threatening diabetic retinopathy is more in males.
No.
Does that mean that out of 100 you picked up 60 were males and 40 were females? Or out of 100 males who turned up, did you have more males who had vision-threatening diabetic retinopathy compared to the proportion of the females?
It was
Did
a
you get my
prospective
question?
study, sir. So we didn't the patients like we got it data collection.
It's simply that out of the patients you picked up, this much patients, a percentage
males
was
and-
males and this
yeah.
much was females. Didn't do a subgroup analysis to see how many males out of those who turned up had VTDR and how many females out of those who turned up had VTDR. That was not done. Okay, why I'm asking this specifically, because there is a gender bias for males turning up to the hospital more than females.